I am very grateful to be able to share this information and go through this process and see it from your lens, because one of my worst fears was being the guy that everybody says, "Oh, he died way too young, but he was so fit." Like, what happened?
Yeah,
And
and what's important for the people in their 20s and 30s that are thinking that atherosclerosis is a disease of older people. Yeah, it's a disease of older people, but it starts when you're young. And most of the stuff that is going to be highly likely to take you out in the 40s and in your 40s and 50s, so 15, 20 years from now, a lot of them will not take you out. There'll be things that are treated as a chronic disease or cured altogether, from everything from cancers to neurodegenerative diseases on. I mean, I firmly believe that. And so it behooves you to address these things now. And we got to get you metabolically right now. Because I can tell just from these labs and from your genetics and family history that you are not metabolically right. I know you're physically fit, but there's a huge difference between being physically fit and metabolically right.
welcome to the Precision Medicine Made Simple podcast, where we simplify the complex world of precision medicine. We're here to explore how personalized healthcare can empower you to understand and improve your health to live a longer and healthier life. Join us as we break down the latest in medical science into actionable insights. Let's make precision medicine accessible and actionable for everyone. Enjoy the show. Today's episode is sponsored by Biography Health, where healthcare meets personalization. With their DNA-enabled blueprint, Biography Health empowers you with a health plan based on your unique DNA, aiming to prevent disease and extend your life. Take control of your health journey with a plan as unique as you. Visit biographyhealth.com and start your personalized healthcare journey today. As a reminder, this episode is for educational purposes only. This episode is in no way a replacement for professional health advice. Please consult with your professional primary care provider for medical advice. If at any point you feel that a topic discussed on our podcast was misrepresented, or if you have additional insights that could enhance our discussions, we wholeheartedly encourage you to reach out to us. Your feedback is invaluable in helping us improve and in ensuring our content remains both informative and reflective of the latest developments in precision medicine. In this episode, Dr. Stanford and I uncover surprising truths from my advanced lipid panel. Despite my active lifestyle, the results reveal hidden risks for heart disease and diabetes. We explore how genetic factors and subtle imbalances can impact long-term health and discuss targeted interventions that could make all the difference. Enjoy the episode. All right, everyone. Welcome to the Precision Medicine Made Simple podcast. I'm here with Dr. Stanford, and today it's going to be a continuation of when my DNA-enabled blueprint was presented. One of the recommendations was to get an advanced lipid panel. And I got the advanced lipid panel. They took some blood, also some urine too. They looked at everything, and we just got the results. And so for this episode, we are going to be going over my results and then talking about what that means and combining my personal history and then family health history too, and where I can move forward from here. So welcome to the show. Thank you again for coming back, Dr. Stanford, even though this is your show.
Thank you for having me
Thanks
on
for
my
having
show.
you
On
on
our
your show.
show.
On our
It's our
show, on our
show.
show. Yeah, yeah,
Uh,
yeah. Our show,
so
our show.
so let's reset a little bit from the you know get the enabled review we did last time.
Mhm.
So a couple of the things we focused on was, one, your family history of premature heart disease,
Mhm.
family history of diabetes, and your personal genetic risk of diabetes and your personal genetic risk of increased lipoprotein little a. So I'm going to switch to a share screen mode. A little review from last time is, all we really knew about you from a lab standpoint was your LDL was 122, certainly higher than desired. Your triglycerides also higher than desired at 139. And we also noted a family history where you had some diabetes, especially on your mom's side, uh, early heart disease, grandmother died of a heart attack at age 64. That's on your dad's side.
And then
And
also my uncle that just passed away from a heart attack at
Oh,
6.
yeah.
Yeah, it is actually
The
at
uncle
64.
that was alive in his early 60s is no longer alive,
No,
right?
unfortunately. Yeah, unfortunately not.
He passed of a heart attack a few weeks ago.
Yes.
So that adds a great deal of urgency to your situation. And I'm going to just scroll down here and take a look at a few things. So the thing that really caught my attention the last time was your risk for lipoprotein little a was elevated. You're in the 87th percentile, although they figure because it's relatively, I'm not going to say rare, but it's not common for people to have an elevated lipoprotein little a. And so if you're in the 87th percentile, that still only equates to an 8% lifetime risk.
In LP little a, for any of those that don't know, can we just have a quick, I guess, summary of what that is?
Really what you need to know about that is lipoprotein little a is one of the lipids that we look at to assess what your risk of heart disease is. Some people would say if you only had, one number to look at that would get your attention, that might be one of them, ApoB, of course, being the other. So one of the recommendations we had made for you, oh, by the way, you see this, your genetic risk for type 2 diabetes was 73rd percentile with a 31% lifetime risk. That's pretty substantial because diabetes is, along with an adverse lipid panel, would be top of the list for risk factors for coronary artery disease. So for you, it's lucky you just turned 30 or you're about to turn 30.
About to turn 30 next February. So not really about, but it's coming up.
Getting close.
Getting
So one of the
close.
recommendations we had made was to check an advanced lipid panel, one that included apolipoprotein B, hemoglobin A1C, get an idea of your fasting insulin and fasting glucose to see if by chance you are on the way to developing that what we call phenotype of diabetes to go with the genotype that shows that you're at risk. And based on whatever we see there, there were further recommendations of considering a continuous glucose monitor and taking some significant steps toward changing your diet, possibly introducing a statin if necessary. By the way, I think I mentioned Dr. John Osborne, who is a cardiologist in Dallas, trained at Harvard. He's also a lipidologist who is the person I've been referencing lately, among others, who believes that because of the long runway for the onset of coronary artery disease, if you identify risk factors driven by family history or other concerns, a low threshold to starting treatment on someone even in their 20s. So keep that in mind. So let's take a look. I don't think I've gone over all your labs with you. Your PSA is fine.
No, we're
Your eye
this
looks
is
good.
this is us going through it for the first time together. So I'm excited. Well, scared also, a little nervous just to see where I'm at.
You certainly have plenty of iron on board, but no indication of iron overload. Your highly sensitive CRP 1.1. We like to see it optimal is less than 1.0. That is an inflammatory, it's a measure of inflammation, and among other things. Ferritin is a indication of iron stores, but it can also be an indication of some inflammation. So between the ferritin of 256 and the HSCRP of 1.1, I'd be concerned that you might have a little bit of inflammation somewhere that could support the idea that you may have the very beginnings of atherosclerosis. Homocysteine is 9.5. We like to see it less than, at 8 or below, because a lower number can be indicative, as Quest lays out here, can be indicative of a functional deficiency of folate or vitamin B12. Now, on your genetics, we did not see an MTHFR variant that would make us think that you would have a genetic predisposition toward a functional deficiency of folate or vitamin B12. So maybe we'll just accept 9.5 here for now.
And so if I did have that MTHFR gene, then that would cause some more
Well, so
concern for
well,
developing gout?
homocysteine is basically indicative of a functional deficiency of folate or vitamin B12. Folate's vitamin B9 and vitamin B12 are super important cofactors in multiple enzymatic reactions. One of them related to methionine and cysteine metabolism, and that's how you get an accumulation of homocysteine if you have a functional deficiency of folate or vitamin B12. You're someone that may or may not benefit from supplementing with methylated folate or methylated cobalamin, which is vitamin B12. It's something we can think about, but this is a lower priority than the other stuff I'm going to talk about.
Okay.
Your glucose of 86, that's pretty good. As long as you're less than 100, you're out of the pre-diabetic range for that particular factor. Your liver function tests were okay. So you're in the normal range for AST of 24. ALT of 32 is a little high for a young person like yourself. So you might wonder about the very beginnings of fatty liver disease with an ALT of 32 in a young person.
What's ALT?
So AST and ALT are what's called liver transaminases. They're liver enzymes that in the setting of liver injury, these numbers go higher. We like to see them down around 20. Someone that doesn't drink much and doesn't have fatty liver will usually be around 16, 18, or 20 on these numbers rather than 24 or 32. So if you're looking for a reason to certainly to drink less wine, wine is what you like, right?
Yeah, I do enjoy wine, but I honestly I haven't really been drinking that much wine at all. Like I think maybe once a week now, and there's maybe a glass or two, but that's it. Ever
Okay.
since we spoke about it last time, where we're on this podcast, we were saying we probably should just decrease my alcohol intake in general. But
Your
yeah,
uric acid of 8.6 is out of range high. Is there any gout in your family?
oh, that's a good question. I think I might have potentially a family member or two that might have gouts, but none that I can name off the top of my head.
So we can look at, the fact that you haven't had gout uh, is helpful, but this is certainly, alerts us that you're probably at risk to develop gout at some point. Yet another reason to minimize alcohol consumption because that can lead to gout. There's certain things you can do from a dietary standpoint also to decrease your uric acid. From a supplement standpoint, there's a supplement called tart cherry, which is said to reduce uric acid levels a little bit. That might be a supplement I would recommend for you. Tart cherry, T-A-R-T, and then cherry, C-H-E-R-R-Y.
Heart cherry. Okay. Oh, this is good to know. Um, because I've had friends that have had gout, and I've heard it's just not fun, and
It's
this has
not fun,
been
and
a
it can
concern.
lead to kidney stones as well.
Oh no.
So although
Okay.
your urine's looking pretty good, I don't see any blood in your urine that would make me think you might have some non-obstructing stones. So that's good. We can do something called a litholink study, a 24-hour study of your urine and see how much uric acid is in your urine and see how close you are to developing uric acid kidney stones.
Hmm.
That's something we should consider.
Hmm.
Vitamin B12 and folate levels. Most people would say that these levels are suboptimal. I think if you did supplement with some methylated B12, methylcobalamin, about 500 micrograms, half of a milligram, and folate, probably about 600 micrograms, you would get that number up closer to 20 and this number up closer to 700. And that's where most people think the sweet spot is. You're vitamin D deficient. I recommend supplementing with vitamin D. Probably start with 5,000 international units per day. And again, tart cherry. And by the way, having uric acid crystals floating around can, in addition, prior to causing full-on gout, can cause pain in your joints in general, can sometimes explain unexplained pain. So that uric acid is something we should do something about and follow, because you do have these slight elevations of your, slight elevation of your, I mean, I wouldn't even call that an elevation. It's just higher than desired.
Yeah. And could that joint pain then be, I mean, really anywhere? Like, could it be in my knees? Could be in like my back, like
It,
my hip area?
so if you've known anyone with gout, it tends to start like in your thumb or big toe. Do you ever get pain in your big toe?
No, okay, that's good. I don't get any pain from my big toe, but when I was younger, I think I did fracture my big toe because I was trying to break dance and I landed on it and I never got it fixed. And so that's the extent of the pain that's come from my big toe. But aside from that, no pain for right now. Well, hopefully ever. But so that's an indicator then if, let's say, my uric acid doesn't go down, then am I correct in my understanding and thinking that way? A correct line of thinking?
Yeah, I think, it's just something we can keep an eye on. I mean, you're a young person with a long life ahead of you. It's just something to keep in mind that you're probably at risk for gout and kidney stones.
Hmm.
And so, two things about that. One, we can be proactive about it. That's what precision medicine's all about. We see that you're at increased risk. We can take steps now. Why wait for the kidney stones? Why wait for the gout? Why not just address it and monitor it throughout your life? Your A1C of 5.4 is not in the pre-diabetic range, but it's certainly not the hemoglobin A1C of someone that avoids sugar and is completely metabolically healthy. So that shows us we have some opportunity there. And this is what I wanted to look at. So you were fasting for these labs, right?
Yeah.
And so an insulin of 8.5 is in the normal range, but it's not normal for someone that's fasting. When you're fasting, your insulin levels should be around 2 or 3, certainly less than 5. Yours is up at 8.5. That tells me that you most likely have some degree of insulin resistance. And this alone is going to make me want to see what you look like with a continuous glucose monitor.
Good thing I ordered that. I haven't picked it up yet, but it's something that I need to order. Well, and so question on the fasting.
Did I you were going to try to get one of those over the counter ones?
Yeah, well, I think Abbott had a free trial, and so I just have to pick one up over at my local pharmacy. Well, quick question then on just the fasting part of it, because I believe I definitely fasted for over 12 hours, right? It was just water. Is that enough time? Like, would you
Yeah,
recommend somebody to
no,
try and
that's enough
fast?
time.
That's enough time. Okay.
Yeah,
Even if somebody had like a steak, let's say like 14 hours before. Not saying that I did, but
yeah, no, that's fine.
okay.
And by the way, do you eat a lot of meat? Are you one of these rabid carnivore types?
Uh, yeah. Yeah, I am.
So that's probably also a source of the uric acid. So, I
Oh,
would encourage you to go online. And one of the things you're going to want to look at is dietary tips for reducing your serum uric acid via what you consume. We could even do that together.
yeah, I would love to do that together. And so I'm just assuming then a lot more fish then. And does chicken also fall into that or mostly red meat?
I think it's mostly red meat, but sad to say, I wouldn't consider myself an expert on that.
Ah, it's okay. Red meat and pork. Well, that's like the staple of Filipino food, of just like my culture's
Yeah,
food
well,
in general.
we're starting to see the issue with Filipino food here,
Yeah. All right.
and
Okay.
why you have a rich family history of diabetes and coronary artery disease, because the genetics don't pair well, apparently, with the standard Filipino diet. The standard American diet, they call that SAD. So the standard Filipino diet would be the SPD. So your cholesterol higher than desired, your HDL 45 is okay. Triglycerides of 203 is crazy high. So you have hypertriglyceridemia. That together with the HDL, excuse me, high triglycerides with your higher than desired LDL, uh, that tells me that we need to be very aggressive with you. You're definitely someone I'm going to want to start a statin on, or start some kind of aggressive. I mean, you're going to do the dietary stuff. We're going to need to do that for the triglycerides, which, by the way, uh, so add also to your shopping list at the vitamin store, could just be CVS, is fish oil. You're going to want to do fish oil a gram twice a day, will help get those triglycerides down. And yeah, as you say, eat more fish and less red meat, and less
Oh,
and fewer Filipino desserts.
yeah. And
I
fewer
can't remember
tacos.
your fiance Filipino or not Filipino.
Whoa, girlfriend, not fiance,
Oh,
just
did
yes.
I escalate?
No, 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 no. I mean, we've been together for over 4 years, so it's that. But not fiance yet. Um,
What does who cooks in your house? You or her or both?
we do both, but I would say she does more cooking than I do, and I definitely need to cook more. And then also, I don't think the taco stand near my place also helps out either with how accessible and delicious some of these tacos and burritos are.
I get the feeling that tacos aren't as big a problem here as the desserts. Where you,
Really?
yeah,
So I
I
can go
mean this.
crazy on the tacos now and just not eat. I'm just kidding.
No, 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 no.
Okay.
Now we're gonna have to try a few things, and I think we're gonna have to do a few interventions. So, for example, fish oil twice a day for sure.
Okay.
You're going to have to avoid things like ice cream and fatty red meats, etc. Try to get these triglycerides down. Avoid alcohol. Again, go online and say, what's a good diet for someone with high triglycerides. You're going to see some of those things I mentioned and some things I haven't thought of off the top of my head.
Okay. Oh
We
man.
got a breakdown of your LDL, and everything is unfavorable. So again, can tell right now we're going to want to put you on the statin. The particle number way too high. Uh, optimal is less than 1138. You're twice that, and you're almost twice the high limit of 1409. And your particles are small. So we talked on the lipid lecture that you don't want a lot of small lipids, because they're the ones that get into the artery wall. I would hazard to say that based on what I'm seeing here, you most likely have your some degree of atherosclerosis underway even at age 30. So it's time, Taylor. It's time.
I am so glad we are doing this podcast and I'm sharing this as vulnerable as this is because like it
Yeah, by the way, thank you for being willing to share this experience with people listening here.
yeah, of course. Well, and even just, and I know we're still going through this because I see ApoB and we're going to be talking about that, but just as like a reaction to all of this, I mean, I am very grateful to be able to share this information and go through this process and see it from your lens because one of my worst fears was being the guy that everybody says, oh, he died way too young, but he was so fit. Like, what happened? And
Yeah, and what's important for the people in their 20s and 30s that are thinking that atherosclerosis is a disease of older people. Yeah, it's a disease of older people, but it starts when you're young. And most of the stuff that is going to be highly likely to take you out in the 40s and in your 40s and 50s, so 15, 20 years from now, a lot of them will not take you out. There'll be things that are treated as a chronic disease or cured altogether, from everything from cancers to neurodegenerative diseases on. I mean, I firmly believe that. And so it behooves you to address these things now. And we got to get you metabolically right now. Because I can tell just from these labs and from your genetics and family history that you are not metabolically right. I know you're physically fit, but there's a huge difference between being physically fit and metabolically right. I suspect you have early fatty liver disease. You have some degree of insulin resistance. Your cholesterol your lipids are pretty undesirable. So this B pattern, so they wind up giving it a grade ultimately of an A or a B, where A is favorable and B is unfavorable. Of course, we didn't need to look any further than 6 red rectangles here to know that it was going to be unfavorable, but it is unfavorable. Your apolipoprotein B of 112, I would recommend that we treat you and the LDL and apolipoprotein B. We get those down to around 40. We want to get your fasting insulin, certainly as an initial goal, under 5. And I know you're a very disciplined guy, so we're going to be able to do this.
So oh man. Oh, geez, this is like.
And your hypertriglyceridemia, we need to get that under control.
Yeah. This is wow. This is so surprising. Because I mean, I honestly thought I was doing okay going into this, but this is what this
Well, you
feels
are
like.
doing okay. I mean, if you look at you,
Right.
I mean, and this is worth exploring. The people listening don't see you with your shirt off. Now, I haven't seen you with your shirt off either, but I have seen you in person, and I can assure everyone that you're incredibly physically fit, and you have a high muscle mass, which is why you're doing as well as you're doing. But it's not enough. It's not enough to overcome your genetics to keep you from getting diabetes, coronary artery disease, metabolic syndrome. It's all shaping up right here.
How much of this is based off of my genetics versus the lifestyle choices that I've made?
So it's both. So it's your genetics, and by the way, your genetics wind up playing into your lifestyle also, right? Because your genetics are Filipino, and so your lifestyle also follows Filipino culture. So I think that the way that Filipino culture, and keep in mind, I'm a doctor, so I've met quite a few nurses from the Philippines, male and female, and I know the food culture, and I know the food selections, which are incredible at the potlucks, but you always thought in the back of my mind, I sure hope no one has genetic tendencies toward diabetes or heart disease based on what I would see at those potlucks. But that also goes with the standard American diet. So what I'm saying is you're going to have to break out of that pattern a little bit. You're going to need to adjust what you eat, and maybe even adjust how it is you exercise. But having a lot of muscle is good, but you're also going to want to do those types of cardio that improve your metabolic health. And I'd refer you to Peter Attia's book for that.
Oh man, I gotta give that chapter
You need a lot
another
of
read
that
then.
zone 2, 80% max heart rate, hour-long cardio stuff. Do you do much of that, or are you more into weight training?
I mean, I do weight training, but then I try and play basketball at least 3 times a week. I used to be a really big dancer too. Well, because I was formerly a professional hip hop dancer, but since I've been out of the industry, I haven't done that. And that I feel like really got me to that zone 2 to 4
Yeah.
of my heart rate. But I definitely need to do it more now.
Yeah, you're just one of those people though that is going to have to modify their diet and essentially completely eliminate foods with added sugar. If you pick up something and you look at that food label and it says there's more than 3 grams of added sugar per serving, you need to just put it back down. And so that basically means all those great desserts and that I don't know what they call that coconut dish that's like in a brownie pan when it's about that thick and it's basically a coconut flavored creme brulee kind of thing that's a
Yeah,
Filipino. Oh, I remember. So you're probably only going to be able to have
just a
one
bite.
bite of that. You know,
Oh man. Oh, okay.
you
This
need to
actually,
be watched closely. So when I say closely, we need to recheck these. Not we need to make some of these modifications, like adding the fish oil and tart cherry and vitamin activated methylated B12 and folate, and see where we wind up. And a continuous glucose monitor is going to be hugely informative. You'll be able to see on your glucose trace. I wouldn't be surprised if you go eat at your parents' house, you're going to get a big spike and then it's going to come crashing back down. And the reason it comes crashing back down is because you have a certain amount of insulin resistance, and insulin is required to get glucose into the neurons. It was really funny. I think you quoted me one time as saying the insulin's needed to drive the glucose into the muscle in your head. There's no in your brain. There's no muscles in your brain. The neurons in your brain, the insulin is required to move the glucose into your neurons. So you're going to find as you get less insulin resistant, you probably start thinking better, and you'll also develop more endurance and more strength because you'll be more efficient about moving glucose into your cells when you need it.
Hmm. Okay. Wait, go ahead. I have a follow-up question.
Go ahead with your follow-up question.
Well, so going back to the sugar conversation of just avoiding added sugar.
Yeah.
Now, I feel like this can be a very controversial topic considering there's technically no sugar and no calories. But what do you think about the alternatives for those 0 cal sugars that are in, let's say, like a Diet Coke or
Yeah.
Diet Pepsi?
So I don't like that because here's what can happen. So things like Diet Coke, if you actually take a sip of Diet Coke and you take a sip of regular Coke, there's a huge difference. One of the huge differences is the Diet Coke is about 100 times sweeter. So a lot of times these foods with artificial sweeteners, they'll throw off your rheostat, so to speak, of what you consider sweet or what you consider tastes good. So one of the things you're going to, if you can discipline yourself to avoid things like Diet Coke and to avoid things with artificial sweeteners, is then you're going to find that natural foods taste so much better. You don't need, the fructose corn syrup stuff and processed energy bars and whatnot to think something tastes good. So one of the things I noticed is that when I stopped using artificial sweeteners and really reduced the amount of sugar in my diet in general, in addition to being able to think better and have the satisfaction of knowing that you're at decreased risk for cancer if you can decrease that insulin resistance and decrease your average blood sugar. In addition to those good things, I also noticed that things like carrots and celery, would you believe that carrots and celery are actually sweet? They're sweet.
Really?
So if your
Hmm.
taste buds are not used to being bombarded with creme brulee and ice cream sandwiches and Diet Cokes, cut all that stuff out and let your I don't know, the more usual term, the engineering term would be like the rheostat of what you consider sweet, the thermostat, so to speak.
Right.
You'll be amazed at how good natural foods taste. I'm
Oh
just throwing
man.
that out there. I had to learn the hard way myself, and I'm sure one of these times we're going to have to talk about my journey through all this, but suffice to say, I'm about to be 64, and I spent the first 60 years of my life abusing my body pretty bad. So,
Okay. You look great for
so
64 though.
it takes one to know one. I'm late to the party, but I'm definitely at the party. But that's one of the more interesting things I learned. I would have never known. I had no idea that carrots were actually tasted sweet. They don't just taste good, they taste sweet. You go, oh my God, that's sweet. And then you taste
Mm.
something like an apple, and it's like a sugar explosion in your mouth, or
Wow.
like a pear, and of course a peach. But most people would agree those things are sweet. But if you're not used to eating food with added sugar or with these artificial sweeteners that are 1,000 times sweeter than sugar, then you're really caught off guard by just how sweet they are and just how great they taste.
So I do recall another quick conversation on so the alternative sugars. Does that also have an impact on heart disease too and what it can do to your body? Like,
Yeah, so
is there a link to
there's I haven't seen a lot of great science on that topic, but I will say that there are reports, you can find papers where it definitely can throw off your microbiome.
hmm,
I think that at the end of the day, just as not being, I wouldn't consider myself a nutritional expert per se, but at the end of the day, I think the most damage it does is it makes you crave sweet things. So we like sweet things. We're programmed to like sweet things. And if you think from a paleontology standpoint, when we're running around hunting and gathering, certainly a fruit tree was a great thing to find, and so was a beehive, and honey was a great find. But we've now, in our modern society, with this, food abundance we have essentially, and these engineered foods by the big food companies, they make it so you want to eat it and buy more of it and eat more of it and buy more of it. And you need to pull yourself out of that cycle. You're going to have to pull yourself out of that cycle and re-engineer your approach to food. And I can tell you the easy start for you, that we're fortunate to have a lot of food labeling where they tell you how much added sugar there is in various things. And if it has added sugar or it has artificial sweeteners, I would tend to just try to put it back, start with the added sugar, and then try to eliminate the foods with artificial sweeteners and get into those natural foods.
good to
And of
know.
course, with your triglycerides, it gets a little more complicated than that, because you're going to need to not only eliminate ice cream and sugary foods, but you're going to have to, again, limit your alcohol and eat more fish and less red meat, et cetera.
So in your experience in what you've seen with previous patients with somebody that has data and results like this, sort of a morbid question, but how if I kept on the same pattern and habits and lifestyle that I have kept on going in this same path, when would I have
Yep.
started to see issues? Would I have started to see issues, do you think possibly like within the next 5 years, 10 years? Did I catch this early enough?
Given that you're kind of into fitness and with the basketball thing, you probably would have done okay toward your 50s. And of course, as your life gets more complicated and you get married and have kids, of course, there goes the basketball and blah, blah, blah. Uh, I think you're on trajectory to have pretty severe heart disease in your 50s.
Oh,
And you're on trajectory, if you didn't know any better and you're just hanging out in the hood, and you weren't clued into finding out about your health, you would have become diabetic.
Okay. Wow. All right. This is very eye-opening. In a great way. In a great way. Because it's like
Yeah,
it's a realistic check.
but with this knowledge that you're already insulin resistant, you may have a little fatty liver, your triglycerides are they're bad. I mean, that's triglycerides of 200. I don't know if I've even seen that recently.
Oh no. Ah.
I'm just being honest with you.
No, it's good. I appreciate the honesty here. It's like I wanted to be
Yeah, I
special,
mean,
but not
even
that type of
mine, I told
special.
you how trashed I was when I started trying to turn some of these tools toward myself several years back. But I think the worst my triglycerides ever were maybe 150,
Wow.
which is bad. I mean, but 200 is diagnostic. You have a condition called hypertriglyceridemia.
Right. It is not my identity. I can change it. I can change it.
That's
There's
right.
there's lifestyle factors that I can change. And
I'll
so,
guarantee you, if you get yourself kind of going in the right metabolic direction and adjust your diet, not only will they be in the normal range, I wouldn't be surprised to see them down closer to 100. I do have a recent patient besides you with hypertriglyceridemia, but you've got her beat by a bit.
oh, not the place I wanted to be number one in. Okay.
And
And
let me normalize it a little bit. One of the reasons that that's not a common thing for me to see is most people that are coming to me to do whole genome sequencing and do this personalized precision medicine approach are already pretty conscious from a dietary standpoint. So the one thing that this patient from actually literally from yesterday, the disadvantage she has is her genetics predict that she's like in the 98th percentile for risk, for genetic risk to have hypertriglyceridemia. So her phenotype fits the genotype. She also, like you, had and I'll have to see if these traits run together. She also was predicted to, from a genetic standpoint, to have a high lipoprotein little a, whereas yours was only 31, I think. If I recall, maybe we'll pull that back up again. Hers was like 130, so her genotype and phenotype fit perfectly. Why is that good for you? So what's good for you is that even though you have genetic risk to have a high lipoprotein little a, it is not that elevated at 31. It's not severely elevated. And your high triglycerides, you got the old fashioned way by eating it. It doesn't appear to be your polygenic risk score to have high triglycerides was not that high. So it tells me we're going to be able to change your diet and modify a couple of things, and that number should come right down.
that's good to know. Yeah, and it's like I've said before, it is empowering to know. And with if you didn't tell me to get this advanced lipid panel then on the podcast, and of course, I guess this is more of like a board question of some sort, but like would other docs be able to have a very similar response to this and seeing the
Yeah,
data and the
yeah.
results?
So I'm going to go back to your Get the Enabled report. And I'll put that back on a share screen because one of the things that just occurs to me is we had triglycerides on you from,
Oh, we did.
and they were kind of on the high side. I mean, 139, just to let you know, what you're shooting for here is about 50 to 60. So people that eat nothing but cardboard and run, 40 miles a week, their triglycerides are usually in the 50s, 60s, 70s, like that.
And my triglycerides now, so that's 139. What are my triglycerides now?
Over 200, 203.
So they got worse. Didn't even improve.
And you see your lipoprotein little a here was only 31, which is a relief.
What
Because
about
lipoprotein little a at this point is one of the more difficult ones to treat. Statins don't move that number. PCSK9 numbers will take it down by about 20%. But the good news is, and like for my patient yesterday, that there are drugs in the pipeline now that are what are called antisense oligonucleotides. We talked about this on the last episode, that will shut down production of lipoprotein little a and knock that number down 80%. So whenever that drug comes out, I think that my patient from yesterday is going to want to be on it.
And then what about my ApoB? I mean, it seems like it's in range.
It's 112. It's high, similar to your LDL.
And is ApoB in?
And here's the thing though, is you see how optimal is less than 100? The optimal of less than 100 is if we assume you do not have any atherosclerosis. But I think if you look at your insulin resistance and other metabolic derangements, including the hypertriglyceridemia, you're going to have atherosclerosis. And I don't have any scientific study I can point out that you want to have a 30-year-old and drive them their lipoprotein B and their LDL, you want to drive down under 50, just because you presume, because of their multiple risk factors and family history, that they would have early stage atherosclerosis at your age. I can't point to a study, can't point to a single guideline that does that. Although, if you as I say, John Osborne, he's a MD, PhD cardiologist trained at Harvard, whole 9 yards, and the National Society of Lipidologists and American Fellow of the American College of Cardiology, et cetera. He is in favor of treating people like yourself now and not waiting. So you had asked, would other doctors have on a standard lipid panel have picked up the problems here? And the short answer is yes. We had those labs from before. Someone that knows that is proactive and preventive would have picked up on that unfavorable lipid profile, even without knowing the lipoprotein A and ApoB. Hopefully it's going to be a thing of the past sooner than later that doctors don't check those things. I have no idea why they don't check this stuff. Can't explain it at all, but I think they will in the relatively near future because, well, I know they don't because there's no guideline that says you should. I think there are guidelines now that say you should check lipoprotein little a at least once and ApoB, but yeah.
And ApoB is inherited too? Is that, or is that mostly
ApoB,
lifestyle?
we talked about during the
Previous episode.
The lipid episodes is often associated with LDL but also with other lipids that wind up getting into the artery wall. And if I'm recalling the explanation of the pathophysiology, so to speak, that the apolipoprotein B that's integrated with the LDL is part of what makes it sticky in the artery wall, what makes it go in and become inflammatory in nature and attract macrophages and scavenging cells, which sets off, inflammation. So your highly sensitive CRP of being 1.1, well, I mean, that certainly wouldn't set off alarms in anyone, except, in the context of everything else we're seeing, I think it may reflect some atherosclerotic coronary vascular disease in you. It could be indicative of that. It's one more thing to look at.
Right.
So, yeah.
Okay. Whew. feel like I need to
So you
go on
have your work cut out. So what's fun
yeah,
is we have a future podcast to see
how I
what
did.
our interventions do. So
Yeah.
we can recap our interventions a little bit. So you're going to address those triglycerides by doing those things I mentioned, avoiding foods with added sugar, uh, avoiding fatty foods like ice cream. You're going to minimize
Oh,
alcohol. You're
sorry, I
going to
love ice
do a
cream.
fillet instead of a ribeye and salmon instead of the fillet, whenever you can get yourself to do that. I still have trouble getting myself to do that. And the uric acid, you're going to do a little tart cherry. We'll see if we can address that. With the homocysteine, lowest priority thing, but you might do some methylated folate and methylcobalamin. You can order those online off of Amazon.
And then fish oil.
Fish oil, a gram twice a day. Oh, vitamin D, 5,000 IUs a day, international units. I would seriously consider starting a statin.
And as starting a statin, would that be like a low dose statin? Like
Yeah, I
how would
might
I go
start a
about
low.
that?
Yeah, I always, we always in medicine, we always start low and go slow.
Okay.
We, as I say, you're not going to have manifestations of this disease like a heart attack. And the stat of how do most people present with heart disease?
How do most people present with heart disease?
Yeah. How do you find out most people have heart disease?
Um,
The
they have a heart
coroner
attack.
tells you that's what they died from.
Oh,
Most people find out most people don't ever find out they have coronary artery disease. The family finds out when the patient has a massive heart attack and dies. So the most
like
common
my
presentation
uncle.
is sudden cardiac death.
Yeah, like my uncle.
Yep.
All right. Okay. Eye opening.
These dietary changes, really the main thing is let's try to get you metabolically right. It might be kind of fun to do a liver ultrasound on you but I don't know. I don't feel strongly about that. We can just do the dietary changes and see if we can reverse get your liver enzymes more toward optimal. Yeah, I think that should do it for now. And let's do those interventions and come back in 3 months and repeat these labs. What do you think of that?
I am excited to go on this endeavor. I I keep reemphasizing this. Nervous, surprised, but now I am pumped up to be able to take action and really try and address this because there I don't like seeing all red blocks. It's just not a fun feeling at all. Okay. All right. Thank you so
Well,
much, Dr. Sheldon.
if you're a superstitious person or a religious person, our paths crossed and you wound up going down this pathway for a reason. I know one of the reasons that I pivoted from the type of healthcare that I was practicing before in the mainstream healthcare system, the so-called break and fix, where no one really asked my opinion about anything until something really bad happened to a patient, and then they come to the ER and you try to piece them back together. And of course, eventually you start wondering, gosh, wouldn't it have been better if we could have somehow intervened before? And the science of today allows us to be predictive of where the risk is. And so we use genetics and close analysis of your family history. And we got some really not very esoteric labs. By the way, all those labs, cash price to less than $200. I mean, it's not like you're talking like an arm and a leg, to find out this stuff.
Hmm.
That lipid panel, that with all that information, the cash price is like $85.
Wow.
And you can know all those things about yourself.
Yeah.
So people out there just need to find doctors that are oriented toward prevention rather than being reactive, and using the science of today to be predictive. You can see where those areas of higher risk are for certain chronic diseases in the individual patient, and then address those aggressively and sooner than later. Yeah, and a 30-year-old. Yeah, and a 25-year-old. You don't have to wait until they're 50 and get a coronary CT angio and go, whoa, what's this? I can promise you that that's how medicine will be practiced 20 years from now, 10, 15 years from now. It'll be done the way that we're doing it. It'll be done in a proactive way.
Hopefully sooner rather than later.
Why wouldn't you?
Yeah. Great words to end. Thank you so much, Dr. Stan, for this eye-opening episode. One of my favorite episodes and empowering episodes that we've had.
Well, thank you for, and I do want to stress this was your idea. It's not like I said, hey, why don't we show everyone your labs? Right down to the fact that I haven't really looked at them that closely. Well, they just came back a couple of days ago, I think. You got to see what this looks like, in real time, so to speak.
Yeah, we get to share this experience together. But I have to say, I am grateful that we have crossed paths and I'm able to be in the right place and have this conversation with you and being guided by you. So thank you so much, Dr. Stanford. And I hope our listeners can take away a lot of knowledge from this too, to really just get into prevention and take action.
Well, you're welcome, Taylor. And thank you so much. You did. This was really a fun podcast.
Fun episode. Fun is a fun way to put it. Eye-opening. All right. Cool.
All right. See you later.
Thanks for joining us on the Precision Medicine Made Simple podcast. If this episode inspired you to learn more about your health, please leave us a review and share the podcast with a friend. Your feedback helps spread the word about the power of precision medicine. Remember, taking action today can lead to a healthier tomorrow. See you next time.